But what is the biggest antibody we have?
That's IgM, Doc. So one more thing, Doc. I just wanted to... how many more minutes will we do immunology, Doc?
We have exactly 2 hours.
2 hours?
Yeah.
So do you think we can finish this and then go to cardiology also at the same time, Doc?
Yes. I will try to finish as much as possible. Now I will go a little bit quicker. But main points.
Little bit quicker.
Yeah. So speaking about the IgMs.
1 second, Doc. 1 second. Sushan just wants to say hi.
Doc. Hi, Doc. How are you?
Hey, man. How's it going?
Good, Doc. So, Doc, I was thinking, Doc, in case you guys can complete cardiology, I was thinking Snigdha's class is 1 hour 15 minutes, right? We'll just do 1 hour 30 minutes every day on the weekdays. And every 15 minutes every day, you can just finish the cardiology review, Doc, if you don't finish it.
Done.
Okay, that sounds good, right?
Yeah.
Yep.
Only 15 minutes every day, maybe 1 page, 2 pages.
Yeah, 2 pages.
You can do rapid review.
Yeah.
Done. No problem.
Okay, Doc. Thank you.
Just in case if we don't.
Yeah.
Thank you, Doc. Awesome, Doc.
So let's take a look here. We have an IgM case. So we have a J chain that connects different antibodies to each other. So the largest antibodies we have is the IgM. The smallest is the IgG. Notice the IgA is a dimer. So if they mention a dimer antibody, it's the IgA. Okay?
Yeah.
Okay, good. So the next thing I want to ask you is which complement is in the classical pathway?
Classic pathway is C1, Doc. C1, 2, 3.
Well, can you tell me what about the alternative pathway?
Alternative will have C3b, Doc.
Okay, good. So can you tell me, please, which opsin do you know?
C3b and IgG.
Good. Next question is about early complement deficiencies. They lead to deficiency of what exactly?
So they will lead to SLE, Doc. Early leads to SLE.
But be careful. Not only SLE. I will repeat this. All of the students get this wrong. Not only SLE, also pyogenic infection. Yeah?
Yeah, pyogenic infections, yeah.
Yep. So the next thing is, can you tell me, please, regarding the terminal complement? What else do they have in terminal complement deficiency?
Terminal, they will have neserial infections, Doc. Recurrent neserial infections. C5, C6, C9.
Yep, that is correct. Can you tell me, please, in C1 esterase deficiency, which is an inhibitor of the complement pathway, these patients have contraindication of consuming which drug in addition to ACE inhibitor?
Oh, contraindication along with ACE inhibitor is what else can cause that one? Probably something that inhibits bradykinin breakdown.
What is that?
ACE inhibitors inhibit that. Oh, okay. Even maybe... Okay, that is not...
Sacubitril.
Sacubitril. That's what I was going to tell. Nephrilicin inhibitor. So that will inhibit angiotensin 2. So... And
also bradykinin destruction. Not only angiotensin 2. Okay?
Oh, okay. So, that also bradykinin. Okay.
Yep. I have one point to say. When we spoke about Wilson disease, I don't know why I'm obsessing about this one. This is the accumulation in the cornea or in the iris?
In between, Doc, in the desmin layer, desmin membrane.
The desmin membrane is in the cornea or the iris?
Cornea only, Doc.
Yep, it's in the cornea. A lot of students think it's the iris because it's like here on the.
Yeah.
Yeah, but it's wrong. It's the cornea. Okay, that's good. Good. The desmin layer. I like the fact that you were specific. You told me it's the desmin layer exactly. Good. So if the patient has an increased amount of bradykinin, what is the big deal? Which pathology they can develop?
Angioedema, Doc.
Okay, angioedema. That is correct. Well, can angioedema have respiratory symptoms?
No, Doc. They will have edema, laryngeal edema maybe, but...
Yes.
Yeah.
So it's possible.
Yeah. possible.
Good. Speaking about paroxysmal Dictorial hemoglobinuria, what do you know about that?
Paroxysmal, it's basically defect in the PIGA gene, doc, that they will have hemolysis at the night time. So that will cause anemia and also all the free hemoglobin that goes and binds to the nitric oxide. So there won't be any nitric oxide, and that will cause vasoconstriction. No nitric oxide, so that will cause smooth muscle contraction. That smooth muscle contraction can cause abdominal pain or erectile dysfunction or dysphagia. Okay, these three, and then maybe the anemia. So there will be all the hemoglobin is lost in the urine. So that's why hemoglobinuria, and that might cause renal failure in them.
Okay, that is correct. And can we speak, if we speak about this paroxysmal Dictorial hemoglobinuria, when the symptoms are worse, morning or night, and why?
It's worse in the night, doc.
Actually, early morning, but okay, but why?
Early morning, okay.
Why?
Why?
Because basically this thrombosis will be activated by BCO2, okay? And you know that the BCO2 in a human being increases physiologically during the night, yeah?
Yeah.
Okay, good. So one more thing about this patient. What are they showing here?
So when you leave it alone, that turns into dark urine.
No, it's actually not when you leave it alone. It says by itself it's red, okay?
Okay.
The one that you leave it alone and it turns black, what was that?
Alkaptonuria.
Yep, and that was a deficiency of what?
Alkaptonuria is deficiency of alkaptonuria.
It starts with a hemi.
No, starts with what, doc?
With an H.
Alkaptonuria. Hex. No, that is not this one. Alkaptonuria. I know it comes in the phenylalanine pathway.
Yep, it's this one. Hemigenistic acid oxidase, okay?
Homogenesis. Yeah, doc. Sorry. Yeah.
Okay, good. So moving on, we have the following. So, okay. So can you tell me the function of the interleukins one by one, quickly?
Okay, one is acute phase cytokine, doc, and also it is a osteoclast activating factor. And 2 is basically for producing more T cells, natural killer cells, and 3 we have 3. Oh, it acts like a GM CSF, doc. Basically, it increases all the stem cells. And then 4 is for interleukin 4. It's for forever, IgE, and class switching of IgE. And then 5 is for eosinophils and IgA. 6 is again a TNF alpha. 6 and TNF alpha are basically acute phase cytokines along with interleukin 1. And interleukin 7, no idea. 8 is again chemotactic agent. We have no idea about 9. 10 is interleukin 10 and TGF-beta are anti-inflammatory.
Yep.
11, no idea. And 12 is again Th1 cells, producing Th1 cells. So important for macrophages and production of macrophages or granuloma formation.
Excellent.
And interleukin 13, basically interleukin 13 is 13. What is 13, doc? Oh my god.
IgE
it comes
production.
under the TH also.
IgE production, yeah?
IgE, okay, yeah.
Okay, good. So respiratory burst, excellent knowledge about interleukins. That was good. So,
Okay.
Speaking about the respiratory burst, which cell does it?
Respiratory burst is neutrophil stock, basically.
Yep, excellent. Well, does the neutrophils only kill using the oxidative burst, or they can kill in another way?
Neutrophils kill. I think the other way also, Doc. But
Yeah, the
neutrophil
phagolysis.
oxidative
Yeah,
respiratory burst is the most common.
yeah, but they can also consume and eat stuff. Yeah.
Yeah,
Okay.
like phagocytosis.
Yep. Yep. Speaking about the respiratory burst. Can you explain what happens exactly?
So when the neutrophil takes in the bacteria, no, Doc, to kill the bacteria, first oxygen is taken by the cell, and then the oxygen is converted into superoxide with the help of one second, Doc. Superoxide only, and with the help of NADPH oxidase, and problem of here will cause the CGD. And this superoxide gets converted into hydrogen peroxide with the help of superoxide dismutase. Hydrogen peroxide is again broken down. Chloride is again added to the hydrogen peroxide to become I don't know what is that. That is bleach. Basically,
Yes.
it's
Like the bleach for the toilet. It's the exact same thing actually.
Yeah. So it becomes the bleach, and that breaks down the cell membrane of the bacteria. So releases all the contents of the cell. And that's all, Doc.
Okay, good. Really good.
Okay.
So speaking about the this thing, if we have a deficiency of G6pd, this guy, yeah.
1 second, no? Okay, I just closed your screen so that I don't see the answers. Yeah.
Oh, that's good. Okay, if we have a deficiency of G6pd, which drug we cannot take?
All these sulfa drugs and
Which food?
food is fava beanstalk.
Okay, and which country is famous for fava beans and the G6pd deficiency?
African American stock?
No, Egypt.
Egypt, okay.
Yep. Okay.
Okay.
Good. So moving on, we have these free radicals creation from the bleach basically kill the microorganism. Yes. So
Yeah, Doc.
if we have a defect in the oxidative burst, which organism are most likely to get us infection?
Catalase positive organisms. So.
Which organism are these? Can you tell me which organism are these?
So catalase positives are cats needs places. Needs is nocardia, Doc. Places P is pseudomonas. L is listeria. A is actinomyces. Aspergillus. And E is E. coli. S is Staphylococcus aureus. S is serraceous. Needs places to bletch. B is Burgdorfia sapia.
What was that?
I don't know how do you pronounce it properly, Doc. It's Burgdorfia sapia.
Again?
The cystic fibrosis organism, Doc. The Berg.
It's painful to pronounce it. I know.
I know. I don't know how to pronounce it, so I always say Burgdorfia.
Oh yeah.
Sapia, and then bletch hair bones. Hair is H. pylori.
Yep. Okay, good. And can you tell me what is the function of interferon, and is it normally secreted or only as a drug?
Normally also it is secreted, Doc.
By whom?
No. Interferon gamma is by the Th1 cells, Doc.
What about the other two?
Alpha, interferon alpha. Not TNF alpha, it's interferon alpha. Maybe the CD8 cells, Doc, because it's mainly for viruses and...
Actually not. Look,
no.
If you have a cell, and this cell, any cell in your body, and it gets a virus inside of it, it sends a rescue message. This rescue message is the interferon alpha and beta, which warn the cells around it that there is a virus in the barometer. Yeah?
Okay.
Which make them make their immunity much more stronger and decrease the permeability of the cells around it. Yeah?
Okay.
So it's basically secreted from all of the cells.
Okay, but only as a response for the virus.
Yep. Can you give me a minute, please?
Yeah, sure, Doc.
Sorry, I had to take some water.
Oh, no problem.
Okay. So speaking about the interferon beta, the interferon beta and alpha can lead to, basically, they are secreted normally from any cells to warn the cells around it that it was a viral infection. Can you tell me, please, for which diseases do we use interferon to treat? Interferon beta, to be more exact.
Beta is for multiple sclerosis, Doc, during the acute flare of the multiple sclerosis.
Not that during the acute flare. During the acute flare, we will give steroids.
Oh, IV steroids. Okay.
Yep. So
just regularly only we give them during regular time only we give them interferon beta, Doc.
That's correct. Yes.
Yeah, and gamma we give them during CGD, chronic granulomatosis disease, and alpha we can give them in any viral infections like Kaposi sarcoma or HBV, HCV.
That's correct. And also you need to know the adverse effect of this interferon. Which adverse effect do you know?
Neutropenia, Doc.
Okay, what else?
Interferons. Depression? Okay.
They can lead to depression, yeah. Okay, do you know the cell surface proteins for various cells? I know that they are alive. Can you tell me which one for macrophages?
Macrophages is CD14, Doc, because that goes and attaches to the lipopolysaccharide, and B7, Doc, which attaches to the CD28, and CD40 also because that attaches to the CD40 ligand of T cell, and macrophage. It can have a C3b receptor because it will act as a opsonin also.
Yep.
Macrophage has too many, though.
Again?
Macrophage has too many, that's the problem.
Yeah, that's why I gave it to you. Okay. Speaking about the natural killer cells, do you remember which ones?
CD16 is for the FC region of the IgG, and CD58 is for the NCAM, Doc. 56.
Okay. Can you tell me, I'm going to speak with you a little bit now about active versus passive immunity. So if I give a patient IgGs, is it active or passive immunity?
You're giving IgG, Doc?
Yes.
IgG, immunoglobulins. I think that's passive, Doc.
Yes. What about if I'm giving him a vaccine that activates the immunity?
That's active.
Okay, that's good. If he is infected?
Active.
If he gets the vaccine?
Active.
If he gets the toxoid?
Toxoid also is a vaccine only, no, Doc?
Yeah, so?
So, active.
Antitoxin?
No, that's passive.
Okay, that's good. Okay, can you tell me, please, which live vaccination do you know?
Live vaccinations can be anything other than RIP.
I want to conclude two systems at once, okay?
Okay.
Which virus can lead to a pink eye and has a live vaccine?
Adenovirus, Doc.
Which virus has two vaccines? One of them is alive, one of them is dead. And that come on, let me finish. Okay, and it destroys the anterior horn of the spinal cord. Polio.
Yeah, polio.
Which of them is alive? Which of them is dead?
So Salk is killed, Doc, and Sabin is the alive one.
Yep, that is correct. Remember the mnemonic: staying alive. Yeah.
Yeah, staying alive. Yeah.
Okay, good. And if we speak about, regarding this one, a virus that, which vaccine they used to think that it causes autism, not anymore.
Autism.
It's wrong. It's wrong. To start with, this theory is completely wrong. But It's highly famous between the people, between the anti-vax. So that's why you need to know about.
No idea, doc. Autism.
It's the MMR vaccine, okay?
Oh, they used to think that causes autism?
Yep.
MMR. Okay, nice.
They used to think that it caused it, and there is a paper about it, but it was confirmed that paper was false. But some anti-vaxxers still follow it. So, if we speak about the inactivated vaccine, which inactivated vaccine do you know?
Oh, your voice is breaking, Doc. What was the question?
Inactive.
It's still kind of cracking in between.
What about now?
Yeah, Doc. I think it's better now.
Which vaccines are killed?
Killed are rabies, Doc, RIP. So I is, one second. I is influenza vaccine, RIP is polio salk, and hepatitis A, Doc.
Yep, that is correct. So what is a subunit vaccine? What does it mean?
Subunit is basically the protein part of the vaccine, Doc.
Okay, can you give an example on it?
Maybe HPV, Doc?
Yeah, HPV.
Because we use,
And in HPV, the vaccine covers which subunit?
The E6, E7 protein subunits.
No. Which types, I mean? Which types?
Okay, 6, 11, 16, 18, Doc.
Yep. So does it prevent formation of warts?
Yeah, not the hand and foot skin warts, no, Doc, but
genital warts?
Genital warts, yes.
Okay,
because
excellent.
6 and 11 are involved, and 16 and 18 cause the CIN.
Yeah, they prevent the cervical cancer, yeah?
But not vaccine, yeah, cervical cancer.
Yep. Should men take the HPV vaccine?
Yes, Doc.
Why?
Because they are very prone to have anal warts.
What? Not gay men, like straight men.
Yeah, even straight men can also have penile warts, no, Doc?
Yes, that's correct. Well, let's say they are circumcised, so they will not have that. Should they get? Should they get the HPV vaccine?
I think so, Doc, because they can have.
They can have head and neck cancer. Yeah.
Oh, so true vocal cords have still squamous cell carcinoma. I mean, the epithelium, so...
Yep. They can have head and neck cancer, remember? Also from HPV. So, even mentioned. When I went to my physician to take the HPV vaccine, he was confused why I wanted, and I'm a man. I want to explain this fact for him. He was like, oh. Yeah. So,
1 second, Doc. 1 second. So, Sushant is just telling that there's a epithelium document, Doc, a document about all the epithelium.
Yeah, I sent it already. It's here.
He sent it to you, Anta. Can you send that to me once, Doc?
Yeah, of course. Now, let me...
He's just not able to find it, so...
just a second. Files. And where it is, just a moment.
So this group has all the files, Doc?
Yeah, like the ones I make, you know?
Yeah, so the ones which you keep sending, so this group will have all of them.
No, the ones that I sent for you, these are different.
Okay.
This nobody has.
Oh, okay.
And don't send them to anybody.
No, I won't, Doc.
Okay, good.
Yeah.
So... but keep doing them. The more I send you from these files, trust me, just do this and you will be fine.
Yeah, done, Doc. Okay.
So, hypersensitivity types, we have type 1, 2, 3, 4. So, if we speak about hypersensitivity type 1, you said it's mediated by an IgE. Can you give me an example on it and how much time it requires?
So, any eczema or allergy, asthma, Doc? Within seconds or minutes only after the second exposure of the antigen, we will have the symptoms, Doc. During the first exposure, just the IgEs are formed. And during the second exposure, there will be binding of all the IgEs. then the mast cell is degranulated
Okay, good.
and releases all the histamine and all the contents inside the mast cell, doc.
Yep, that is correct.
Prostaglandins, histamines, yeah.
Good. So next, so it takes seconds to occur. It's like an anaphylaxis. It can occur in a bee sting and a lot of things, yeah?
Yeah, bee sting, anaphylaxis.
What is the best way to check for an allergen?
The pinprick one, doc?
Yes, and if you don't have that as a choice answer, what you will choose? ELISA for that antigen, okay?
Okay, ELISA for that antigen, nice.
Okay, good. So the next thing is type 2 hypersensitivity reaction. If they ask you about a form of hypersensitivity reaction that can lead to formation of antibody against the basement membrane, what is that?
Good pastures, doc?
Okay, what about Albort?
Alports is the basement membrane's antibodies only, but there will be collagen 4 problem, doc, in them.
Yeah, so Albort is a deficiency of collagen.
Collagen 4 deficiency.
Yep, and no antibody.
They'll have can't see, can't pee, and can't hear a bee.
Yep, so there is no antibody related to it. Yes?
Yeah, no antibody related to it.
So the next thing, if we speak about the Graves' disease is which form of hypersensitivity reaction is it?
Type 2, doc. Type 2.
What about rheumatic fever?
Rheumatic fever molecular mimicry is type 2, doc.
Okay, ready for the trick? Lupus.
Lupus. Autoantibodies against that. It can be, but it's basically the symptoms, the systemic symptoms of all the organ damages is because of the immune complex deposition, doc. If it is lupus nephritis, then the immune complex deposition, so type 3, doc.
Always?
Yeah, I think.
Well, no. Here is the thing. Lupus, the organ damage, like kidney, heart, all of that, it's type 3. You are right. But the hematological symptoms, this is type 2. Like the hemolysis.
Okay.
Okay?
Yeah.
Okay, good. Can you tell me regarding type 3 hypersensitivity reaction? We know that it's mediated by immune complex. What is an immune complex?
Antigen, antibody, and complement, doc.
Yes. What is the difference between serum sickness and Arthur's reaction?
Serum sickness and Arthur's reaction, doc. So serum sickness occurs just after 14 days, 7 to 14 days after the antigen attacks, doc. So they will have fever, rash, and arthralgias. And it can be because of any drugs or any treatment problems, doc. So after 7 days, and Arthur's is maybe a longer duration, doc?
Yep. Which one is systemic? Which one is regional?
Systemic is serum sickness because it has arthralgias also.
Yep, it affects all of the body. Yes, but in Arthur's reaction, it's only at the place of the injection. That's it. Okay.
Okay.
So it's localized. It's a localized form of reaction. It's not all over the body. Yeah.
Okay.
This helps you to differentiate between the two. You don't have to worry too much about all of this process. Just the location.
Okay.
So speaking about type 3 hypersensitivity reaction, we spoke about the serum sickness. Can you also tell me what does the word hapten mean? Hapten.
Haptens.
Yeah.
Oh, are haptens the ones that bring the no, those are antigen presenting cells. Haptens also something like that only, though.
So what are they? What are haptens? What happens are basically structures that are not antigen. They are not antigen, okay? But they can attach to a carrier molecule from your body, okay? And if they add to your body, they will become antigen, okay?
Okay.
Like, for example, penicillin. Is penicillin an antigen? No, it's not.
No.
But if it attaches to some immune complex, it can become an antigen.
Yeah.
Got it?
Yeah, doc.
Okay.
Yeah.
Good.
1 second, doc. 1 second. Just 1 second, doc. Sorry. Hello?
Yep.
Doc, can you hear it?
Hear what?
Yeah, can you hear me now? Yeah.
Oh,
Sorry.
yeah. I hear you perfectly.
Okay, doc. Okay.
So, I was asking regarding the type 4 hypersensitivity reaction. It's mediated by which cell?
The cell-mediated cells, doc, CD8 and CD4, doc.
Okay, excellent. If we speak about this, the BDD test. BBD test. It's for checking for TB.
TB.
Which form of cell is leading to this reaction?
CD4, doc.
Okay, good. That's it. They keep tricking students with choosing CD8. It's wrong. CD4. Okay. So, can you tell me, please, except of the TB skin test, what other skin test can we do?
Contact dermatitis, doc, or we can even do.
Speaking of the devil, contact dermatitis. It creates which type of lesion on the hands?
Tract lesions, doc. What was it?
Yeah, vesicles and vesicles, basically, yeah?
Vesicles, yeah.
Okay, good. So, do you remember, this is just a recall, if we speak about the oxygen dissociation curve, do you remember that?
Yeah, doc.
So, if someone has, basically, this T3 BBG? 2,3 BBG.
BBG, yeah, doc.
If it is decreased, what will happen to this curve?
Decreased as it moves to the left, doc.
Yes, so it becomes like this, yeah?
Yeah.
If someone has, what else will shift it to the left?
If they have any low temperature or pH being high, or less oxygen, anything that decreases, I remember it as left, doc. And if it's in the highest, how do you call that? Straight, if it goes straight and right, then that's myoglobinuria.
Okay.
And
if we speak about fetal hemoglobin,
that's opposite. Fetal hemoglobin, if increased fetal hemoglobin, then left shift.
Left shift?
Right shift.
Right shift?
That is also like all of them. So if more hemoglobin, more fetal hemoglobin, then right shift.
No, it's left shift as well. Okay?
Okay, that's opposite. Yeah.
Yep, it's
So
left
dog,
shift.
you're just tricking me.
Yep, it's like the 2,3 BBG, yeah? It's
Okay.
exactly the same. You must know that. Okay, good.
Second dog. So 2,3 BPG, if it is low, how is it shifting?
Left. Basically, let me give you this trick. I like to think about it like this. If you have low hydrogen, you shift to the left. If you have less CO2, you shift to the left. If you have basically low BVG, you shift to the left. If you have high fetal hemoglobin, you shift to the left. Okay?
Yeah. Okay.
If you have like reduced temperature, to the left. Any one of from these weird ones, like more carbon monoxide, more methemoglobin, and more hemoglobin F to the left. If they want to trick you between the carbon monoxide and the hemoglobin F, be careful. Carbon monoxide curve is like this. Okay? Fetal hemoglobin, however, is exactly like decreased 2-3 bbg. Okay?
Yeah.
Make sense?
Okay. So carbon monoxide becomes like a partial agonist curve, doc. It
Exactly.
was halfway. Okay.
Yep. Good. So let's go back. It's nice. I feel like you are in your last steps of preparation. You already have idea about everything, and that's good. So you just need a couple of pushes, and you will be there.
Yeah.
So let's keep going. We have the next thing. We have the blood transfusion reaction. If I transfuse blood to a patient and suddenly he have anaphylaxis, what is that?
IgA deficiency, doc.
Okay, good. And how to prevent it in the future?
We give them washed blood products.
With which process it's washed?
Which process is it washed? No idea, doc.
Leukoreduction. Okay, leukoreduction. Okay.
Mucoreduction. Okay.
Okay, good. So next thing, we spoke about this process, yeah. Actually, sadly, you need to know this actual ones. For example, if we had, for example, this one, NADB oxidase, NADBH oxidase. If it's deficient, if it's not working, what will happen to the patient? He will have problem going forward. Yes.
Yeah.
Yep. So where is superoxide? Yeah, superoxide dismutase will be released. They will not be okay.
Second.
Yeah. So you must know about every single step of these ones, sadly.
Yeah.
It's actually important. This concept is high yield. Okay. Anyway, moving forward, there is something important I wanted to show you, which was here. So if we speak about the patient who had basically not an allergic anaphylactic reaction, but instead he took the blood after 30 minutes, he started having fever and he started having basically tachycardia and tachypnea. What do you think happened to him?
I think it's acute, doc, because of ABO incompatibility. He has acute hemolytic reaction.
Yep. So it just was like delayed. It's not that delayed. It's like 30 minutes. So
30
it's
minutes,
considered acute. And it just if you don't have ABO incompatibility as an option and no RH incompatibility as an option, choose something called anti-kill. Okay? Anti-kill. Kill.
Okay.
This anti-kill is a form of like the ABO system and the RH system. It's basically just a minor antigen. Okay?
Okay.
This is a recall. Be careful about it. Next one.
Okay.
Febrile non-hemolytic transfusion reaction. If we speak about this, it's febrile. So, of course, they will have fever. But it's non-hemolytic, which means they will not have any hemolysis, not increased bilirubin. Why this happened? Basically, the blood has been staying there for a long period of time, so it started releasing the blood.
Cytokines.
Yeah, but which cells secreted the cytokines? Either the RBCs or the white blood cells, the neutrophils?
WBCs only.
Yeah, the WBCs. So these WBCs start releasing a lot of cytokines, and when you give this blood to the patient, he will have basically cytokine storm in his body. Yeah.
Okay.
So he becomes flushed. He's sensitive to it.
Okay.
Can you explain for me, Trali?
1 second, doc. I'm just writing what you just told before. Yeah, no. So about Trally, doc. So when they have any antibodies, anti-leukocyte antibodies, doc, when they form any anti-leukocyte antibodies against the blood products, there will be pulmonary edema, doc, actually.
Okay.
So I know it's vague, whichever I told. So, and I know it's anti-leukocyte antibodies.
Which is it, anti-leukocyte or anti-neutrophils?
Yeah, and specifically the neutrophils,
Yep.
anti-neutrophils, yeah.
So, basically, you need to have a primed neutrophils inside of your lung. Yes. So they need to be ready to make this inflammatory reaction. Next, you need to expose them to some antibody from the circulation. Correct? When you have both of these, you can have a TRALI, which is a transfusion-related lung injury. Please write a note. It looks exactly like ARDS. Okay?
Okay.
Like the patient will have this hyaline membrane, they will have this fibrosis all over his lung happening suddenly. It's exactly like ARDS.
Okay.
So how to prevent it? Leukoreduction as well, because it clears out the antibodies. Yeah?
Okay.
Good. So the last one is the delayed hemolytic transfusion
Delayed
reaction.
hemolytic.
Oh, by the way, if they ask you which cell is destroyed, you say endothelial cells, okay?
Okay, doc. Yeah.
Because also in ARDS, it's the endothelial cells destroyed.
Endothelial cells, yeah.
Now the delayed one. Tell me about the delayed one.
So, delayed is similar to the RH incompatibility. I mean, the erythroblastosis fetalis, doc. So basically, during the first exposure, during the first exposure, just the very small amount of response happens to the antigens exposure, doc. And when they're re-exposed, the small response whichever produced during the first one will already produce the memory B cells. And these memory B cells or T cells will come and attack and make a very big reaction during the second exposure.
Okay, good. So
Animistic response. This is called animistic response. And this similar to erythroblastosis, no, doc?
Yep. Erythroblastosis fetalis. It's similar to it, but the main idea that it takes time after a really long time, yeah, to occur. And they have not intravascular hemolysis, but extravascular hemolysis, which means
Extravascular hemolysis.
Which means it occurs in the spleen, yeah, and the liver. Okay. So if I tell you that someone have an antimitochondrial antibody, which disease he has?
Antimitochondrial is primary biliary cholangitis.
Okay. Antiphospholipase A2?
Antiphospholipase A2 is membranous nephropathy.
Excellent. And if I tell you that he has an antiglutamic acid decarboxylase?
Celiac, doc?
No. Antiglutamic acid decarboxylase, that's type 1 diabetes. For celiac, it's the transglutaminase, transglutaminase.
Okay.
Yeah, I told you that. I was exact about this one because they sound the same, you know? Yeah, so it's kind of...
So anti-transglutaminase is celiac. And anti-glutamic acid decarboxylase.
Yep, it's diabetes. Can you tell me about...
Diabetes.
Yeah, antimicrosomal antibody.
Antimicrosomal antibodies is microsomal autoimmune hepatitis, doc?
No, that was anti-smooth muscles
One
antibody.
second. No, that is smooth muscle. Microsomal is thyroid, Graves, doc.
Yep. Also, you are right. It can be autoimmune hepatitis. That's new. Okay, awesome. I did not know that.
Oh my God, even I didn't know that. 1 second. That was a clear guess. 1 second. Antimicrosomal also, type 1. Okay.
Nice. Well, the next thing we'll speak about immunodeficiency. I hope you know. First of all, I will not go over all of them. I will just give you the point you need. So, How can you
Okay.
differentiate on the exam between X-linked agammaglobulinemia and common variable immunodeficiency?
X-linked is in children less than 6 months and in boys, doc. And in a common
What
variable,
did you
it's
say?
mostly seen in girls and... Sorry, doc?
Repeat what you just said.
So I told in men, in boys less than 6 months of age.
No,
Sorry,
after
more
6
than
months.
6 months of age.
I was like,
After the 6 months of age.
okay.
Oh my God, you listen to us. It's in bitsy pieces also, doc. Yeah.
Oh, yeah.
So common variable is more than 2 years to adolescence, doc,
Mhm.
and it's seen in girls mostly.
Mm-hmm. Well, it's not sex specific, that's the thing. But the protons, it's
Okay.
mainly
Yeah.
boys. Okay.
Mostly boys.
Yep. What happens to their tonsils?
They are also atrophied, doc, because there won't be any tonsils because there won't be any B cells maturation or production.
Mm-hmm. What about
So-
their thymus?
Thymus will be fine, doc, because there's no problem with the T cell maturation.
Yep, exactly. Thymus will be fine. Okay, good.
Mm.
Speaking about this selective IgA deficiency, which type of transfusion reaction they can have?
Type 1, the first one, doc. What is the first one called? Anaphylactic allergic reaction.
Yep, okay, good. And can you tell me, please, in case of selective IgA deficiency, they have increased risk of what? They don't have IgA, which protects what?
So all IgA is mucosal infections, doc, increased risk of recurrent bacterial or mucosal infections, basically.
Mm-hmm. That is correct. Okay, good.
Mm.
And especially Giardiasis, yeah?
Yeah, doc.
Okay, good. And can you tell me, please, speaking about this selective IgA deficiency, you also need to know its association of one of the malabsorption syndrome. Which one?
Celiac, doc?
Yes, celiac disease. Okay. Well, speaking about the thymic aplasia, and all of these T cell disorder, which organ will be atrophied in them?
Sorry, doc. Thymic aplasia. What was the question, doc?
In case, forget about thymic aplasia. And in case of T cell disorder, which organ will have atrophy in it?
Thymus.
Yeah, good. So all of them, not only the thymic aplasia. But in case of thymic aplasia, can you tell me, please, which chromosome has the problem?
Catch 22, so chromosome 22, doc?
Yes. So what does the little q stand for? Because you know it's 22q11. What does the q stands for?
Long arm, doc? P is short arm and Q is long arm?
Because you remember it's quite long, yeah?
Okay, done.
Good. So speaking about the thymic aplasia, they have what? Failure of what?
Maturation of the T cells, doc.
Okay, and they have failure of the third and fourth pharyngeal pouches, yeah?
Yeah, doc. So the third pouch causes thymus problem, and the third and fourth produces the parathyroid glands. So that's why they'll have hypocalcemia.
Okay, good. So what is going to happen to their BTH level?
Parathyroid will be very high, doc.
Why? There is no gland. How it's going to be really high?
Oh my God, doc. Yeah.
It,
Gee, I was just thinking about the hypocalcemia. Oh my God, yeah, doc.
they don't have a gland. It will be low. And what
Low.
about the calcium?
Calcium is low.
Okay, good. So the next thing, if you have really low calcium, you can get tetany, yes?
Yeah, doc.
Okay, good. So the next thing, interleukin 12 receptor deficiency, that can precipitate
TB.
to... Okay. Well, that's good answer. That was my next 3 questions about that. Okay. So, okay. So can you give the BCG vaccine with someone with this type of infection? This type
No,
of
doc.
Why?
Because there won't be any granulomas formation in them already, and
You know, the BCG vaccine is basically a live vaccine, yeah? So if you give it to someone with zero immunity, to the mycobacterium, you will basically giving him
React
disseminated TB.
the infection. Yeah.
Job syndrome, they have something related to their teeth. What was it?
Supernumerary teeth, Doc.
Which other disease has that?
Gardner's.
Excellent, good. And can you tell me, please, which skin problem they have?
Eczema, Doc?
Yep, excellent, good. And it goes something like this. Which IgE is increased in them? Which immunoglobulin?
IgE, Doc.
Which cell?
IgE.
Yeah,
so
cell. Which
I've
cell?
always for interleukin 4.
Yeah, and cell, which cell will not be there?
Eosinophils, Doc?
Again?
Eosinophils, Doc?
The cell that will be absent is neutrophils because you will have deficiency of T helper 17. Yeah? Remember what I told you about the upper picture right there? I told you cellular, humoral, humoral, and neutrophilic. Neutrophilic is T helper 17, and the deficiency of the interleukin 12 will lead to dysfunction of the T helper 17 as well. Okay?
Yeah, okay, Doc.
Good. So let's take a look here. So the next one is chronic mucocutaneous candiazzes. You told me already about this one, and we spoke about the
Allergen.
Yep, the allergen. Can you remind me which problem these patients had?
So they have autoimmune regulatory endocrinopathy, Doc. So they will have all the autoimmune genes that is causing all the destruction of all the endocrine organs. So that's why they'll have chronic mucocutaneous diseases. They will have hypoparathyroidism, and they will have adrenal insufficiency and recurrent candidal infections.
Okay. So there is an enzyme, when it's deficient, you can get a form of immunodeficiency that...
AD.
Oh my God. So which drug works against it?
Which drug?
Yeah, inhibits AD.
Which drug inhibits ADA? Adenosine deaminase.
Yep. And for which disease is it's used and how it works?
So basically it is used for HGPRT thing, Doc. During the HGPRT sequence, I mean for purine and pyrimidine, just for the sequences.
Well, here's the
HGPRT.
thing. It's pentostatin and cladribine, which are used for hairy cell leukemia, okay?
Yeah, Doc. We add the nucleotides to it, cladribine and pentostatin.
Look, when you inhibit this guy, you will have a lot of adenosine, correct? Adenosine is highly toxic to the lymphocyte, okay?
Yeah.
So it will kill the hairy lymphocytic leukemia. Okay, good.
Perfect.
So let's go back here. Let's speak a little bit about SCID. So is it T cell or B cell deficiency?
Both, Doc. B and T.
So what will happen to their thymus?
Thymic aplasia, Doc.
What happens to their tonsils?
Tonsils are also absent.
What
this
about
was the
their
question
lymph
you
nodes?
asked in the group.
Yep. What about the lymph nodes?
Lymph nodes.
Atrophy.
They will also be atrophied, Doc.
Yeah, because the B cells, the follicles are gone. Paracortex gone. So it will be really small. Yes.
Atrophied. Yeah.
Good. So you must actually know about this decreased T cell receptor excision circles, which is basically a marker. Okay. And you must know that they can have susceptibility to infection of basically everything. Yes.
Okay.
Good. Speaking about ataxia telangiectasia, which process is defective?
DNA repair, Doc.
Which type of repair?
The single-stranded ones. The first one is nucleotide excision, that is for xeroderma pigmentosa. And then this is DNA repair. The second type, doc. Oh, no, third type. Mismatch, doc?
Mm-mm.
No, mismatch is Lynch syndrome, and this is the second type. Base.
Okay, I will give you a trick to remember it. It's non-homologous enjoining, yeah? But how to remember that? How to remember that it's non-homologous
Double
enjoining?
strand.
Because, you know, it's easily forgettable. I get it. But always there is a way. Let me show you the way. It's of my invention. So,
Okay.
first of all, this disease is a double strand defect, not single strand. I just imagine that it's non-homologous enjoining. So one leg is taller than the other leg, yeah?
Okay.
So if you have one leg taller than the other leg, you will have ataxia.
Yeah.
Non-homologous legs lead to ataxia. Non-homologous enjoining. Done.
Awesome.
Got it?
Okay, 1 second, doc. Awesome, doc.
Yeah, I really like this mnemonic. It always like help. It makes it easy.
Nice.
Okay. Have it?
Yeah, awesome, doc.
Good. So in case of ataxia telangiectasia, what you should not do for them?
What we should not do for them?
Put them in an X-ray machine because they would get cancer. Yeah?
Cancer. Yeah, doc. So any kind of radiations we should avoid, doc. Even sun exposure or X-rays or any radiation.
Exactly. Good. So speaking about the hyper-Igm syndrome, can you tell me, please, in case of hyper-Igm syndrome, what is defective?
The CD40 ligand, doc. They're not able to class switch.
Exactly. No, absence of
So
that.
everything stays in the IgM stage only.
Yep. That is correct. Good. So the next thing is something like this. If we speak about the what else do we have here? Yes. If we speak about Wiskott-Aldrich syndrome, tell me the water mnemonic, please.
Wiskott-Aldrich, T is thrombocytopenia, and E is eczema, R is current pyogenic infections.
That's correct. Good. So the next thing is phagocytic dysfunction. Before that,
I got so many about these leukocyte adhesion in the exam, doc.
Oh, they love it.
2 or 3 questions on leukocyte adhesion.
Oh yeah.
One was about CD18, one was about beta-2 integrin, and the other was umbilical stumping.
Oh, that's actually important. By the way, before I forget, I saw this question. You know these fibroadenoma, like the breast tumor? So they are estrogen sensitive, correct?
Estrogen sensitive, yeah, doc. During pregnant periods, they grow in size.
Yeah, so just before the period, they become really painful. That's correct.
Yeah.
Also during pregnancy, they are really painful until delivery. They become painless. Why? Because estrogen drops. Yeah.
It's dropped. Yeah.
Yeah. So you need to know that if they have this mass that is painful during pregnancy but becomes painless after pregnancy, this is a fibroadenoma. Really characteristic of it.
Fibroadenoma. Okay, doc.
Okay.
Awesome.
Good. So speaking about the Wiskott-Aldrich syndrome, what is the problem?
Which one, doc?
In Wiskott-Aldrich syndrome, what is the problem?
Wiskott-Aldrich. The microtubules are not able to, actin are not able to form well, doc, in them. So there's cytoskeleton problem in this. VAS gene, Wiskott-Aldrich, VAS gene defective. So that's the actin are not able to form properly and the cytoskeleton is weak in them.
Yeah, so you said they have many problems, yeah? You spoke about which symptoms did you speak about? You spoke about
water, doc. Thrombocytopenia, eczema, and recurrent
pyogenic infection. Okay, that's all correct. But you said something about the microtubules. What did you say about microtubules?
They're not able to arrange properly, doc. The actin filaments are not able to be arranged.
Okay, that was the actin filament here, actin cytoskeleton. But the microtubules dysfunction, that's in Candiazzes Hagashi. Okay?
Yeah, I mixed up both of them.
I felt that. So speaking
Actin is for viscotolerage,
Yep.
and microtubule is for Shidakigashi.
Yeah.
Yeah.
Now
But end of the day, both of them end into a microtubule functionally, no,
Well,
Doc? I mean,
that's
actin
true.
and that will also.
That's the truth. Cytoskeleton is basically like, it has microtubules in it. That's correct?
Okay.
Okay, so I have a question now. Which immunodeficiencies are X-linked?
X-linked is X-linked gamma globinemia.
That's one.
Viscotolerage.
That's two.
Even SCID, not the ADA, but the interleukin 2 receptor.
That's three.
That is X-linked.
What else?
X-linked.
Hyper IgM, okay?
Hyper IgM, okay.
Hyper IgM.
Okay, that is also X-linked. Okay.
Yeah, it's Hyper IgM, okay?
Okay.
Hyper IgM is X-linked. Okay, speaking about the leukocyte adhesion deficiency, it's an dysfunction of the integrin. You must know that. It's the CD18, and that will lead to basically bore migration and chemotaxis. Yeah? So what will happen to the neutrophil count?
It's very high, Doc, because they're not able to go to the site, and they're just hanging in the blood.
Yep. So, but they are dysfunctional though, yeah?
Yeah, Doc.
Okay, so can you tell me which symptoms this patient have?
So they will have delayed umbilical falling, Doc, and there won't be any neutrophils pass at the site of the wound, and very high neutrophils in the blood.
Good. And can you tell me regarding the one more thing? In case of Candiazzes syndrome, it's a microtubule dysfunction, yeah?
Yeah, Doc.
So this microtubule dysfunction will prevent neurodegeneration. It also will lead to a prevention of movement the melanin from the basal layers of the skin to the upper layer of the skin, which lead to albinism, okay?
Okay. Oh.
It also prevent the movement of the fusion, between the phagosome and the lysosome, yeah? And that will lead to what? Recurrent pyogenic infection. It also lead to prevention of movement of neurotransmitter inside of the axons, which will lead to neuropathy, peripheral neuropathy, yes?
Nice. Awesome, Doc.
Okay, good. So it's due to microtubule dysfunction. This is the most important thing. And the recurrent pyogenic infection happened because of a dysfunction of the phagolysosome. Yeah?
Yeah, Doc.
Please do not forget about the giant granules and the platelets, and they can basically have dysfunction of all of their cells. Yeah? They can have pancytopenia. Why? Because the microtubule, they are not functioning, so they cannot move the cell outside of the bone marrow. Okay? So they get pancytopenia. The last one is a chronic granulomatous disease. You spoke about it, but tell me more.
So basically, the NADPH oxidase is deficiency, Doc. So there won't be any superoxide production. So there won't be any reactive oxygen species to fight and destroy the bacteria. So that's why they are very prone to have catalase positive infections. And when we do the tests also, we have two tests. One is dihydrorhodamine tetrazolium test and dihydrorhodamine test, and then nitroblue tetrazolium test. And treatment for this is interferon gamma and CGD.
Yep. Remember that these patients have high risk of this Staph aureus and all of the you said.
Catalase positive. Yeah, Doc.
Yep. Okay, good. So now let's take 10 minutes break. Come back after the break.
Sure,
we finish immunology, then jump for cardiology and finish as much as possible from it. Okay.
Awesome, Doc. Awesome.
So see you in 10. Bye-bye.
Yeah, sure, Doc. Bye.